And so that's moving from the Ministry of Health saying we're just responsible for our sector, where in many countries is a very small part of the healthcare system. And it's also investing in the capacity to do this. It's very difficult. We talk a lot about multi-sectoral action, but working between sectors is hard. It's much easier to stay with our own sector with people who speak the same language as us. But if we don't really take this seriously and invest in multi-sectoral action, we're not going to reduce health inequities, and we're not going to make the progress that's possible in terms of what we want for our communities. And so in the World Health Report, we sort of identify 3 trends that can deviate health systems from these goals of health equity, universal access and healthy communities. We describe hospital centrism, which is a terrible word, but really reflects that there can often be an undue emphasis on specialised tertiary services when people's access to primary care is inadequate. There can be unregulated commercialisation, which often puts other goals other than health first. Now, and that there's often this fragmentation, people very much working in silos. And so leadership is required to move these trends. It's not about building a system up from scratch, it's about working with your existing system and making changes to move towards the goals. To revise, health equity is the absence of avoidable and therefore unfair differences in health between and within populations. And social determinants of health are the structural determinants and the conditions of daily health life which are responsible for most of the health inequities within and between countries. So they're the conditions of daily life. They're where you live, they're where you go to school, they're where you work, and they're your access to money, power, and resources, which are often dependent or affected by who you are, or where you live, or what ethnicity you are, or whether you're male or female, or how old you are, and that many of these things these differences in health are natural or biological. They actually reflect the way we choose to structure our societies, and that this rainbow you may have seen from Dahlgren and Whitehead, which reflects the very complex impacts on people's overall health status. Yes, your biological inheritance is important, but it's only a very small part of the story. It's about lifestyle, it's about social and community networks, it's about all of these sectors such as education, employment, housing, water and sanitation. These days it's also increasingly about the global environment. If global factors affect you wherever you live, whether you're living in a poor village in Malawi or whether you're here in Geneva, the global environment affects your health every day. So this report, and I would recommend you to have a look at this report. Now, the Commission was a 3-year process convened by WHO in 2005 to look at the problem in health inequities and consider how we can move forward to address health inequities by addressing the social determinants of health. It was chaired by Sir Michael Marmot from the University College in London. There were 19 commissioners, ex-heads of state, Nobel Prize winners, senior health leaders, civil society representatives who met 10 times over 3 years and were aided and abetted by a huge number of people. Knowledge networks which focused on key determinants such as employment, gender, globalization, health systems, urbanization, hundreds of experts from all over the world, country partners who work to share their experiences, a strong civil society stream which really brought the experience of civil society, which often has played 2 roles. One, as an incubator of innovation. Civil society has often responded to problems as people present them rather than trying to define them in ways that governments are more comfortable with. And also as advocates, and as powerful advocates for the right to health. And assimilating all this information, this report, which is long, but I do recommend you have a look at it. There's at least a 30-page summary if that's more usable. 3 overarching recommendations: improve daily living conditions, tackle the inequitable distribution of power, money and resources, and measure and understand the problem and assess the impact of action. You might say, well, this is common sense. Did you really need 3 years and a room full of paper and all of these luminaries to come up with this? But these overarching recommendations are a structure to frame a whole raft of more specific recommendations. Most importantly, perhaps, the Commission said that social injustice is killing millions of people, and that health inequities are not biology, they're not nature, they're the result of policy failure They're the result of toxic public policies. And that there are things that we can do about this. Many countries have examples we can learn from. Civil society has examples we can learn from. We just have to have a whole raft of recommendations, and I'm not going to go into detail in them. There are recommendations for WHO around global policy coherence, around the need to make health equity a global development goal and work with our multilateral partners to do so. There's the need to support measurement of health inequities because, as I said, if you don't measure the problem, you don't know. In New Zealand, where I'm from, the key inequity is on ethnicity. Indigenous people live 7 years not as long as other people, and that's simply unfair, and there are reasons for that. But we've only made progress on that, and for the first time we've started to close health inequities after 20 years of a lack of progress, because we've really made a consistent effort to measure health outcomes according to who you are. And then, but it's not just about WHO, it's about countries, it's about this concept of health in all policies, it's about strengthening social protection and universal access to services, it's about measurement, and it's about considering about finance. And that for us as the international community, it's about coherence in monitoring our action. It's trying to avoid this fragmentation that often, in spite of good intentions, is imposed on countries. And it's also about improved participation, not just at the grassroots level, but also considering how everyone is able to participate in our global fora. So we have these reports. So now, what now? How do reports end up in action? Well, reports end up in action through people like you, okay? WHO is an organisation of the people. Governments come and they represent the people. So WHO is an organisation of the people. And I'm sure many of you have been to the World Health Assembly before. You'll go later today or this week. And this is a photo from last year. In this grand, august surroundings, what's it about? It's about the right to health, enshrined in the WHO Constitution, which should be available to everyone regardless of who they are, regardless of their age, gender, ethnicity, sexual orientation, where they live, education level, what they do. That's not just utopian. That's something I think we all believe in, right? So this week at the World Health Assembly, we're going to be discussing these two topics along with a range of others. There's an agenda item on the Commission on Social Determinants of Health. There's an agenda item on primary health care, including health system strengthening. And there are some resolutions that were already agreed to at the Executive Board in January. These will be discussed further. There'll probably be resolutions which come out. But that's not the end of the story either. The resolutions will say WHO is asked to do A, B, C, D. Countries are urged to do A, B, C, D, the international community. Now, whether the resolutions lead to action or not, again, well, to be honest, is dependent on you. It's dependent on who is kept. We should be kept accountable for what we agree to do and we say to do, and countries often are very good at doing that. But in terms of what countries agree to do, it's really about respecting democracy and what communities want. So if countries agree to do things, whether those things end up in changes is really about what people are able to advocate for and hold governments to account for. That's the way the international system works. So in summary, I mean, Fiona will speak, but I'm very happy to take any questions you have, is that primary healthcare and social determinants are complementary approaches to improve health equity and to really affirm the right to health. That's where they're coming from. Now, what that means now for WHO really is dependent on the discussions. It's what member states agree to this week. There is scope for civil society organisations to make statements as well. But really, from wherever you come from, I mean, whether you're a patients group focused on a particular group of people, that's fine. Whether you're a government trying to work out how can you best serve your people, whether you're a staff member working at WHO thinking how can we move forward on our goals, I really do think there is something in both of these discourses that can help you. And both of them really consider this essential question of the distribution of power. Just power relationships for health, which some of those important relationships are within healthcare services, some of them are beyond the healthcare system.